So this is a SHARC research seminar, and we've tried before, and we are now successful in having Dr. Haesuk come to give us a talk. I believe I was on the search committee when Dr. Park applied for a job here from the University of Texas. It's probably 15 years ago. It's been a while, 12 years ago. And we got her to come here, and ever since I've had an opportunity to sort of work with her in various roles, both as a collaborator, as part of our mentoring team, but I've learned a lot from her because she's an outstanding scientist with expertise in sort of interpreting data from large databases, like clinical databases that either have health insurance data, like we call claims data, or electronic health records data. She's been trained in healthcare economics, so she often thinks of things in terms of how do you evaluate, cost benefit or cost effectiveness of different things. Her focus has been on a lot of vulnerable populations. So her K award, for example, she was interested in looking at who gets access to treatment for hepatitis C. And at the time, many programs were restricting access to people who used alcohol or drugs and saying they're not going to get treated. And so she did a lot of research to try to look and see and show that their outcomes were just as good as people that didn't have substance use. And so I think she really has fought for sort of these vulnerable populations. She's done research on substance use, Hep C, and then she's also done a lot of work with PrEP and even looking at HIV incidence in some of these data sets. I've had an opportunity to work with some of her students, and she's worked with students who also come from diverse backgrounds. Her PhD students produce a lot of papers, and it's been awesome to sort of see her succeed. She's currently a tenured associate professor in the College of Pharmacy, Department of Pharmaceutical Outcomes and Policy. And I'm really happy to have Dr. Park here today to talk to us. And the title of her talk is there on a slide. Welcome to Dr. Park. Give her a shirt.
Thank you so much for a nice introduction. Do I need to?
I'm just going to move this so it's not covering up your
Okay.
slides.
Hello, everyone. I'm so glad to be here to share some of our study findings related to PrEP and HIV and sexually transmitted infections. So this is the study conducted by one of my graduate students who graduated last year. We just looking at, we try to understand better the real world use of the PrEP adherence, and then how that is associated with important outcomes such as HIV infections and sexually transmitted disease. Okay, so I'm pretty sure this audience is very familiar with all the statistics, HIV epidemic in the United States. I just update a few numbers. So in 2022, this is numbers reported by CDC in 2024 this year. 1.2 million patients are living with HIV. And in 2022, 31,000 patients are actually newly infected with HIV. Of those, 67% are MSM and 22% are heterosexual contact, and then 7% are who use injectable drugs. And 83% of estimated infections are among all men here in the United States. And then also almost 50% of the new infections are one in South area here. And about 13% of patients with HIV are not aware they are infected. So over 35% of new HIV infections result from individuals who did not know they had HIV infections. So this will lead to the ending HIV epidemic, a plan for America. So as you probably all familiar with this overall goal, we try to decrease the estimated number of new HIV infection to 9,300, which is like 75% reduced by 2025, which is just around the corner. It's like December 2024, and then 30,000 by 2030, but we are kind of far behind our goals. And of those 4 pillars, including HIV testing and treatment, there's an important pillar, which is the prevention using the PrEP and syringe service programs. So mainly focus on the 3rd pillar, the prevention part today. And there are 3 different options for PrEP. So 2 oral PrEP formula and one injectable PrEP. The first one is Truvada, and the second one was approved in 2019, which is Descovy, and the injectable PrEP was approved in 2021. For this study, we'll mainly focus on oral PrEP because the data that we use, we did not really have any injectable PrEP. So what has been known? What do we know about the PrEP adherence in HIV? All those, the randomized clinical trial or open label clinical trial reported that PrEP is associated with decreased risk in HIV incidence. And if we look at the iPrEP trial, overall reduction was 44%. However, the HIV risk reduction achieved 76% when taken twice weekly, and the risk reduction increased when they taken four times weekly. Okay. And achieve 99% prevention when taken daily. And the third study, the iPrEP open label extension study actually suggests that no HIV infection was observed of those patients whose blood spot indicated that those patients are taking PrEP 4 or more per week. And partner PrEP study also indicated HIV incidence reduced by 75% with PrEP, and their adherence was 81%. However, one of those studies, the VOICE trial, focused on the female population. They actually concluded there was no difference between PrEP and placebo. However, their adherence rates were really low, like 29%. And Discover trial compare Truvada versus Descovy. They also concluded 99% reduction in HIV incidence if they take the PrEP 4 more pills per week. So all these studies actually suggest that substantial HIV reductions are actually really good adherence, highlighting the importance of the adherence and what we know in the real world. So real world evidence of the PrEP adherence. So real world evidence is different from clinical trial. So clinical trial, we recruit the patients and we give the medication. It's very limited setting, but real words are the one that physician prescribe and patient take it if they want to take it. If they don't want to take it, they don't take it. So there are a few studies actually evaluate what's the real world PrEP adherence. And the first study used Kaiser Permanente to initiate the PrEP, and then they used the adherence medication possession ratio. I don't know if this audience are familiar with the medication possession ratio or proportion of dates covered. So these are kind of calculation method we use given the claims data and to understand the medication taking behaviors better. So I just try to explain how the data look like. So the data that we use is pharmacy claims data. So what that data shows us which date patients pick up PrEP prescription for how many pills, for how many dates. So it actually indicates January 1st, patient A pick up the PrEP for 30 days and 30 pills. And then February 1st, if they come back and then we see all those data. So we are able to estimate during 1 year time period or 6 months time period, how well these patients adhere to medication. So if they pick up the refills every month as scheduled, the NPR-PDC will say it's 100%. But then let's say if the patients are supposed to pick up the pills like every month, but instead they pick up pills every odd months, let's say January, March, May, then the adherence will be the way that we estimate using NPR and PD. It's slightly different, just ways to estimate, and then we see what we see is 50% adherence. So that's how we estimate. So we often use 80% as cutoff, less than 80% oftentimes considered as a low adherence, greater than 80% is a high adherence. However, it's a 79% really low adherence. Maybe not, right? So sometimes we use 3 different categories, very low, low, and high adherence. So cutoff, sometimes we use 30%, 7%, but 80% is actually very commonly used. So both studies conducted in one in Kaiser Permanent and then one in VA settings, they use 80% high adherence, low adherence, try to understand who is high, who is low adherence. However, as you can see, when we look at 1 year patient's medication taking behavior, let's say if a patient took the medication really well for 6 months, and then they discontinue, and the way that we estimate using MPR PDC will indicate this patient's medication adherence is 50%. However, the same, another patient, this patient took the medication from January to December consistently, but every other day for some reason. Then their patient's adherence will be also 50%. However, these 2 patients are very different, right? Like if we think about PrEP use, these 2 patients are very different. So just using the one arbitrary, we call it as a single measure, sometimes cannot really capture the dynamic changes in medication taking behaviors. And these are some of the challenges, these were 2 extreme cases, but there are also different cases. Some patients take the medication very well, like first 2 months and very low, and then come back again. So we try to capture how this medication taking behavior change over time. So this is, okay, let me explain about the sexually transmitted disease first, and then I'll explain the method we may be able to capture the medication taking behavior better than just PDC or NPR. Okay, so what do we know about PrEP and sexually transmitted disease? So the Proud Fire actually reported that even though patients are taking the PrEP, there's no significant differences placebo versus PrEP. I mean, it's not really placebo. They took the PrEP a little bit later. However, among those MSMs, there are no significant differences in terms of sexually transmitted disease incidence rate. However, other studies, including a meta-analysis, actually reported that the use of PrEP is actually associated with almost a 60% increase in chlamydia and 24% increase in any sexually transmitted disease. So there were some concerns there about potential increased sexually transmitted infection risk due to behavior change among the PrEP users. So what we call is actually risk compensation, behavior change, because I'm taking PrEP, so I'm very safe. So I'm now willing to engage more sexual behavior, not using condom or multiple partners because I think I'm protected by PrEP. So this is the kind of phenomenon that the way they explain is this, because of this PrEP users tend to engage more risky sexual behavior. So this is what has been known. But then we do not know anything about those who adhere PrEP will likely to engage more sexual behaviors, risky sexual behavior, or those who don't take the PrEP. I mean, those who do not take the PrEP on regular basis are engaging risky sexual behavior. So nothing has been known about the PrEP adherence and the risk of sexually transmitted infections. So this is next slide. This is kind of a new method that we can capture more dynamic changes in adherence, medication taking behavior. So most studies use PDC NPR. There's nothing wrong with the PDC NPR. We often use PDC NPR, but we try to advance our knowledge about the PrEP adherence behaviors. So we were thinking about, is there any other method we can utilize to understand these different heterogeneous PrEP users and then understand how their medication adherence change over time. So GBTM is one of the way that it's very recent that the medical field start using this method, but this method has been used in criminals. Like they try to understand how those criminals change their, I guess, behavior related to crimes. So we adopted this method and try to understand we try to map out how the PrEP users adherence change over time, and can we really put like all these people in different groups? So that's what the GBTM for, like group. So like let's say we have all these 100 students or 100 PrEP users in the classroom, and using this 80% adherence cutoff, we just separate those two groups, right? One group here and the other group is here. 80% greater than 80%, less than 80%. However, what this growth trajectory model does, okay, let's see how many groups will be reasonable given the data that we have. So it's not us, we categorize, it's actually programmed, categorize the patients in different groups. Sometimes 3 groups works better, sometimes 4 groups works better, sometimes 5, 6, 7, 8 groups works really well. So there are ways we can test them if this grouping does make sense, if this grouping is good enough. There are some diagnostic testing. So GBTM, in a way, they try to group the people based on their medication taking behaviors. Okay, so the objective. I don't want to overwhelm, but there are some interesting findings. So I want to share some of the results that we did. So the first of all, we will use the GBTM and then identify unique PrEP adherence trajectory groups. Let's see how the program group people differently, and then examine association between the adherence trajectories and risk of HIV and STI diagnosis. And also within the same adherence group, we try to compare STI diagnosis before and after initiation of the PrEP. So that was the first objective. And the second objective, because we experienced COVID-19 pandemic in 2020. Is it 2020? Yeah, right, 2020. So because we included those years, we actually hit by COVID-19 badly. So we trying to understand, okay, so PrEP adherence change before and after, or okay, so pre and during COVID-19 pandemic, and see how the HIV infections and sexually transmitted disease infections change during this 2 time period. So that was our objective. And the method. Okay, so we use market scan commercial claims database. So what is this database? These are individuals who had commercial insurance. I do have commercial insurance paid by my employer, right? So this data set captures, they said like almost 50% of all commercial insured individuals in the United States. So it's a large data. So every year we get updates. So each year, sometimes we have like 50 million people in this data set. So we use data from 2012 to 2021, and we conducted a retrospective cohort study, and we included patients aged 12 to 64 years who were prescribed PrEP for longer than 30 days, the older PrEP only. And we excluded patients who had diagnosis or prescriptions for HIV and hepatitis B virus infection or HIV PrEP during that year before they initiate PrEP. So some patients, if the patient has PrEP for 29 days, they were excluded. And our outcome was HIV infections as a primary and then STI as a secondary. Adherence measured. So I briefly mentioned about the GBTM and also explain a little bit about the PDC. So for this project, we actually estimated the PDC days covered by PrEP every 15 days for 2 years. So if the patients had PrEP for all 15 days, the PDC will be 1. But the next cycle, they have only 5 PrEP out of 15 days, then it'll be 33%. So that's how we estimate the PDC every 15 days. And then this was used for the GBTM analysis. Okay, the primary outcomes was HIV incidence. How did we capture the HIV incidence? So there's a validated algorithm. Either patient has one inpatient visit related to HIV or 2 outpatient visits for HIV. And then we actually follow patients from the index date. Index date is day 31. I have a diagram I can explain better. And then plus 180 days until HIV outcome occurs or end of continuous eligibility and end of study period. So for the main analysis, we follow patients up to 2 years. And then for a secondary outcome, the sexually transmitted disease, we included chlamydia, gonorrhea, syphilis using the ICD diagnosis code. However, if they had a diagnosis chlamydia today and then maybe gonorrhea a week after, then we consider this as one episode, not 2 episodes, because they might be occurring the same time. So, and then we had a slightly different follow because when HIV outcome occurs, we stop looking at their STI outcome anymore. And slightly different from the way that we measure HIV, the reason is that for HIV outcome, we were interested in their first their very first HIV diagnosis. For STI, we want to capture how many STI they had. They are multiple STI outcomes the patient had. And the pre-post study, as I mentioned before briefly, within the trajectory groups, we also look at before and after they initiate PrEP. Okay, the study design, I'll revisit here. So you see the, oh yeah, here. The index day is day 31, which means patients initiate PrEP, and then everybody should have PrEP day 31. And this we consider as baseline period a year before they initiate PrEP, and we require patient had a continuous eligibility 130 days a year before, and then also 30 days plus 6 months. And we excluded any patients develop HIV from day 31 to day 31 to for 6 months, because when we look into this data, some patients had HIV diagnosis in day 32, day 34, right after they initiate PrEP. So we didn't really think this is really associated with PrEP. Sometimes they received the PrEP prescription from from ED without having the HIV test result come back. So this is why we excluded HIV patients who develop HIV immediately right after PrEP. And then this allow us to measure the adherence for the PrEP as well. So 2 years we measure adherence and HIV outcome measures starting from day 211. And for up to 2 years, and STI outcomes were measured right after day 31, up to 2 years. Okay, and then we conducted sensitivity analysis. What we did was we did not stop at year 2. We followed them as long as we have the data patient. Okay, and then for pre and post-pandemic group comparisons, and 2020 was lockdown. Was initiated, so we had a transition period of like about 3 months, and we compared 2 years before and 2 years after. So this is kind of subgroup analysis, so we have much less sample size for this analysis. So GBTM, we use the SAS program, and then in order for us to determine if our GBTM works well or not, we use 3 different methods. The first one, BIC. We use BIC, higher is better. And then we also look at individual trajectory group, just make sure that we do have enough patients in each group. And then visual expectation, conservative conditions, and NIGEN criteria too. So these are 3 methods we use. And then we also use inverse probability treatment weighting to balance across different groups. So these are one of the techniques we often use because it's not randomized control trial. So the patient characteristics will be different across different groups. So we try to balance this one, and then we estimate propensity score and inverse propensity score, just weight those patients, just make sure that all those groups are well balanced. For HIV outcome, because we are interested in very first outcomes, we use IPTW weighted Cox proportion hazard regression model survival analysis. And then we also use time varying covariates HIV testing. I can explain a little bit more about this. So in order to have HIV diagnosis, what need to happen before? Test. So the more we test, the more diagnosis we'll see, right? If we actually test the patients every 3 months versus every year, every 3 months will more likely detect the diagnosis faster. So this is detection bias. It's not like, it's not like this group has a higher risk because we test more. That's why we actually detect more patients. So in order to mitigate these bias, we use HIV testing. So we adjusted how many HIV testing patients receive in time varying manner. Every 30 days, we actually, so this is during they actually take the prep. We actually measure how many HIV testing they had, we control for those. And then similarly, STI outcome, we use for some regression, but because we were more interested in multiple outcomes rather than just first outcomes. And then we also use the STI test because the more they test, more likely there will be diagnosis. And then STI testing, time varying manner, and pre-post analysis was done. Okay, and then here is the result. Okay, any questions so far? Okay, good. Okay, so we started with 142,000 patients who initiate PrEP, and we excluded based on our inclusion/exclusion criteria, like lack of continuous enrollment, younger than 12 years old. So among those who are older than 12 years old and had enrolled to meet the inclusion criteria, we also exclude those patients had HIV medication diagnosis, HPV medication diagnosis, and then also more likely PrEP users rather than PrEP users. So our PrEP cohort, we had 23,258 patients. And then this is a trajectory model look like. As I mentioned, we asked the statistic, the programming to group patients into 2 different groups, 3 groups, and 4 groups, and 5 groups, and you can go up like 6, 7, 8, 9, 10. However, if you have 10 groups, you can't really interpret any differences across different groups, right? So the way that we see, so you see that when we have 2 groups, PIC was 61, like 600, I mean, it's long, 619,077. The more the groups BIB increase, BIC higher is better. So the more groups you have, actually BIC increase. And however, the first one, we only have 2 groups, right? So 40% patients were in this group, 56% are this group. And then this is how we interpret the result. The 30% in 3-group model will be here, 26% and 42%. And then we also run analysis for 4 groups and 5 groups again. So when we saw this result, we were debating, shall we go for 4 groups or 5-group models? And we decided to go with 4-group model. The reason is that when you see this, this one group here, 25% here, I think the reason why, you see in 4 group, we only had 10% patients, minimal user group here, but then 5 group, for some reason, they put a lot of more patients in 22% patients in this group, and this 25% in 4 group seems to be separate in these 2 groups. So this is one of the reasons we did visual inspection, and then we feel like 4 groups doesn't make more sense than 5 groups. And then the next one, we also, so after we decide to do 4 group, and then these are the labelings are the one that we actually make up. Like we just decide, okay, this one is consistently high on adherence group. This one rapidly decline. This is gradually decline group. And then this is minimal user group. So this is it. But then there was one more diagnostic test we had to conduct, which is Nielsen diagnosis test for 4 groups. We actually did this test for 4 group, 3 group, 4 group, and 5 groups as well. But I'm just sharing this information for 4 groups. And the way that we use this testing, we compare the first column and second column need to be similar. The numbers should be very similar. That's how we decide if our grouping works well. And then it was similar, and then average posterior probability need to be greater than 0.7, and which we achieved. And also odds correct classification need to be greater than 5. And then we were way higher than that. So this is how we decided to use 4 groups instead of 3 or 5 groups. Okay, any questions? Okay. Okay. So remember this diagram. Now we have four adherence groups: consistently high adherence, gradually declining adherence group, rapidly decline, and very minimal use. And the sample size were distributed like 9,000, 5,000, 5,000, and 2,000. Okay, so the baseline characteristics across these 4 groups, and as you can see, majority are male. And most of them are actually aged like between 25 to 34, followed by 35, 44, older than 45, and then 35 to 44. And as you see, the patients' age group slightly changed across different adherence group. And then one thing that I just wanted to mention is in the minimal use group, we see the very low adherence group, actually almost 20% are actually female in that group. And we also look at if the patient had substance use disorder diagnosis or STI history before, and or severe mental illness or alcohol use disorder. If we just compare consistently high group versus minimal user group, the patients in consistently high groups are actually healthier, so less likely to do substance use. Less likely to have substance use disorder or alcohol use disorder or severe mental illness compared to this group. And then we use IPTW weighting. What does this is after we weight patients, then we achieve very well balance across different groups. So we use cutoff of 0.1. So all the values that we included were less than 0.1. So this is the 4 groups that we use for our outcome metrics. Okay, the primary outcome, HIV incidence. During 2-year time period, we identified 172 patients newly developed HIV. And we follow them up about 400 days. And we can focus on the adjusted hazard ratio. So I remember that I mentioned about HIV testing, how important that HIV testing need to be considered as time-varying manner. So this is actively controlling for all those numbers of HIV testing patient receive and also actively balance. So this is IPTW weighted Cox regression. So compared to minimal use group patients, in consistently high, gradually declining adherence trajectory group were less likely to develop HIV, and it was statistically significant. The third group, there was no difference, and statistically there is no difference in HIV incidence between rapidly declining versus minimal use group. However, the point estimates are lower than 1, which means it's more likely protected. So, and then we compare individual groups. So we also compare rapidly declining group versus other 2 groups. And then within first 2 groups, there was no statistically significant differences. However, the point estimates are slightly, point estimate indicates there is some protective effect of the practice. And then sensitivity analysis, remember that we did not stop our patients up to 2 years. We follow them forever as long as we have data. And this second group was statistically significantly lower HIV incidence compared to minimal user group in our main analysis, but it actually their point estimated increase and confidence interval increase as well. So what this indicates, the longer we follow them up, was consistently high adherence group is the only group where has significantly lower HIV incidence compared to minimal user group. So this is HIV incidence widget. And the next one, secondary outcome, sexually transmitted disease rate. So compared to minimal use group, as you can see, all these groups, considered high, gradually declining, rapidly declining groups had much higher STI rates. And even the more, our data indicate the more that they adhere and the PrEP, they're more likely to have STI, so much higher STI rates. And then we also look into each individual group to see if the STI rates increase after they initiate PrEP. And what we found is the first two groups who consistently high adherence and gradually declining group, both the groups, compared to before PrEP initiation, after initiation, the STI rates are much higher. So I guess I'll pause here. Just like I want everybody to think about why we see this result. Like, what do you think about considering high adherence groups are the one actually based on the results actually engage with sexual behavior. They are also taking PrEP very well compared to minimal user group. However, the minimum user group are the one, I'll just go back to our adherence graph. So minimal user group, it's possible just based on data, they are the ones, maybe they had the first two PrEP prescription, they never come back to get the refill. And it's possible that they might not engage with sexual behavior anymore. They might not need it. There are different kind of combination of patients, but what we need to remember, among those patients, actually, you see the 2,400 patients do not really take the PrEP any longer. They still develop 21 new HIV incidents occur in this group. So it's not like they don't really need to take the PrEP, but then just want to emphasize that the patient characteristics are very different, the way that they engage sexual behavior. And this is also related to some of the limitation using the administrative claims database analysis. So then the subgroup analysis, we compare pre-pandemic versus pandemic. And then for this study, we only focus on male. The reason is that when we did our main analysis, 20% patients, female patients, were in minimal PrEP user group. So we want to make more homogeneous population for this study, considering the lower sample size. And these are some of the patient characteristics. And then the next slide, we also look at different GBT. Let's see if the pre-pandemic group is different, has different medication taking behavior compared to pandemic groups. So when we want to focus, you see this consistently high group pre-pandemic. When we look at 2 years before pandemic, 46% patients were in this group. However, after pandemic, it decreased to 29%. So there are some changes. The pandemic actually affects the PrEP users' medication taking behavior a lot too. So we saw no adherence was 11% here, but then early discontinuation was 35.7% during the pandemic. And did this really affect HIV incidence or STI rates? Yes, it did. So if you look at the HIV incidence rate compared to pre-pandemic and post-pandemic, we observed HIV incidence increased by actually over 2-fold. So we think this is highly related to adherence, the PrEP adherence that we observed in our GBTM analysis. But then what happened to STI rate? There is no changes in STI. So it's not like the patients are engaging more sexual behavior because we were locked down, but it's more like the way that they have access to PrEP, the way that they can continuously get the PrEP from healthcare provider. Okay, so this is I believe this is the last slide of our result. Okay, so discussion. So what we found from this population-based retrospective core study was higher PrEP was associated with a lower risk of HIV. And this is consistent with main findings from clinical trials. And also higher adherence, PrEP adherence was associated with increased risk of STI. So there must be some risk compensation among this population. And when we compare our findings, pre-PrEP period, higher HIV, but no significant difference in STI rates during the pandemic period. Some of the limitation, it's actually important to understand, we have a large sample size compared to clinical trial, but there is always limitation we need to keep in mind. So because this is a claims database, claims database are collected for reimbursement purpose, not for research. So there is no information whatsoever why patients stop taking PrEP. It's possible they don't need it anymore, or they cannot afford it anymore, but we do not know anything or any of those information, or also sexual behavior. We cannot ask patients like, are you still using condoms or not at all? And we use PDC as a proxy of medication adherence. However, just because patients or individual PrEP users pick up the PrEP from the pharmacy, that doesn't necessarily mean they are taking it, right? We have a lot of medication we receive from the pharmacy, we don't take it at home, right? So it's possible, so we cannot capture that. However, pharmacy claims are very commonly used in order to understand medication taking behaviors. So the conclusions, compared to PrEP minimal use, which is non-adherent groups with consistent high or gradually declining medication adherence trajectory groups were associated with a lower risk of HIV. However, they are actually increased risk of STI. So, we want to just inform the public health strategy and clinical guidelines, interventions, if we can maximize the PrEP use for reducing new HIV infection. We should continuously advocate, individuals need to take, and keep saying patients, but PrEP users are not really patients. So, keep using the PrEP consistently. However, we also need to think about what's the good strategy to prevent STI. So CDC released the doxy PrEP strategy. So the patient take doxycycline with PrEP in order to prevent bacterial STI. But that was released in 2023. So our study did not capture any of those information. I believe, okay, so acknowledgement. You see this was my graduate student who conducted this study, part of his dissertation. And I also want to acknowledge his committee members, Dr. Gooding, Dr. Losiganik, and Dr. Kerr. And I'm happy to take any questions.
So you include people with commercial insurance, that doesn't include Medicare and Medicaid, correct?
Correct.
So no one who maybe has lower income to qualify for that was excluded.
Correct.
Okay, do you think it would be different rates of HIV and STI prevalence or incidence if we looked at lower income?
Yes, it's possible. Really good question. So we tried to actually use Medicaid data. However, there are very few patients we see who using PrEP among Medicaid beneficiaries. So yeah, the findings we see here is only generalizable to commercially insured patients, not other patients who do not have insurance or who has Medicaid.
I apologize if I missed this, but I'm wondering to what extent the differences between the individuals who are followed for 2 years versus people who had followed for 70 days. These are slightly different associations. I'm wondering to what extent that could be explaining the differences in the people who had more follow-up data.
Yes. Oh, okay. So your question, I'm sorry, I heard some, okay, so your question is, would patients who had a longer follow-up time, would it be different patients who had shorter follow-up time? Yes, there are some, it's possible because this is again, commercial insurance. So if someone loses job, they're not, we don't see their data anymore and their continuous eligibility act. So there might be some compounding factors, those who lose jobs, I don't know, risky behavior, and then, those who continue to stay here. Yes, there might be some differences.
Some of our team's been having some conversations with the RB about identifiers of data and whether data is anonymous or limited identifiers, and I wonder if you could talk about any of the. Does this data have any identifiers like dates in it, and what are some of the issues related to privacy and
Yes.
ethics in dealing with data set like this?
Yes, so this is considered as limited data set by IRB US. So this data set has all the dates, service dates. What date that they see patient, what date they see physicians, and what date did they pick up the prescriptions. However, we do not have any identifier like, zip code, patient name, social security number at all. Only dates that we have is service date.
How do you know it's the same person?
Oh, we do have de-identified ID. The market scan sign of patient's ID. And so, for example, if the patient has a job and they cover by commercial insurance, and then they lost job, they come back again, we can follow them up. So it's the same ID they use.
The last question is for the group. I do think the continuous enrollment is important, but maybe could you explain what is continuous enrollment and how can you tell if someone's enrolled but just not going to the doctor versus someone who's out of the database?
Yes, we can help. So there is an enrollment file. So we know individual patients, what day they were eligible for the insurance and what day is the end of the enrollment. And then so that's why we require patients to have continuous eligibility during the study time period. Otherwise, we cannot tell if this patient had insurance, did not come back, or this patient did not even have insurance. Go ahead.
I guess as a follow-up question for that, controlled for time varying HIV testing as it, I'm wondering to what extent you might have missed HIV testing that wasn't done through the person's insurance.
Yes, correct. It's possible that some patients received HIV testing out of his network, some free HIV testing. We are not able to capture that. But what we think is those missing data or miscoded data, incorrect data are similar across different groups.
Hey, Violet, can you see if anybody online has any questions or?
I think you had a question. Yeah, go ahead.
So I'm wondering how you could generalize a study like this to compare between the groups that are now on injectable PrEP versus taking a daily basis. If you're measuring like once every 15 days, and if they're doing once every few months, it seems like they're going to be difficult groups to compare. And I would be really interested to see how these results match or don't match across groups taking these kind of different medication types.
Very good question, because now we are really interested in injectable PrEP, right? How that would work in your work. So, I mean, if we really want to compare their adherence, we can try to do that, but it's different formula, so it's really hard to compare. So our groups are actually currently one of my students are actually comparing the HIV outcome between these two groups. But we only have less than 30 patients in our data. But we are getting 1 more years of data by the end of this year. So hopefully we will have more patients that we can actually compare. We are actually really interested in, before we look into adherence, we're actually interested in is the real world HIV incidence rates will be different between these two groups. So that's the next question we try to tackle. And then after that, we will try to see if we can really compare the adherence using GBTM, maybe not, but we'll come up with something. Good question. Any other question?
There's an online question.
Okay. So that's a very good question. So on-demand use, again, this is one of the caveat that when we use administrative claims data. In our data, it looked like the patients pick up PrEP prescription for 30 days. However, this patient does not really need to take the PrEP every day, but then they might save some and then take it when they're on holiday. So we do not know. We cannot tell. So there are some assumptions we have to make. Did I answer your question? But then based on our observation in our data, most of the patients actually had at least 28 days of refill, not like 3 days, 4 days, 5 days. I don't know if that helps. Okay. So most of them actually had 28 days or 30 days of supply. Any other question? It's okay.
All right. So I'm gonna bigger after the talk, for those of you who are here, for those of you on Zoom, thank you guys for attending.